The most common type of vertigo we see related to ENT is benign paroxysmal positional vertigo. At the same time, Meniere's disease and vestibular neuritis are also frequently encountered. Additionally, we have patients who present with vertigo complaints due to cervicogenic vertigo, which can be associated with neck pain. What can you say about this?
Yes, actually, it's not something that comes to mind very often. Vertigo originating from the neck is more of a feeling of dizziness rather than true vertigo. In other words, vertigo caused by the neck presents more like a sensation that the ground is slipping away. Our neck is not only responsible for supporting our head, but it also plays a very important role in balance. There are various sensors here in the spine, muscles and tendons called proprioceptors. With every movement of our head, these sensors send signals to our brain, informing it of our position in space. But if there is any problem here, meaning if there is a trigger point or a spasm in the spine or muscle, these signals become disrupted. The brain receives correct information from the eyes and ears, but the information coming from the neck is incorrect. It has difficulty interpreting these signals, and as a result, a sensation of dizziness occurs, which is similar to vertigo and feels like the ground is shifting. Unlike the types of vertigo you're familiar with, this kind of vertigo is more often triggered by head movements. In other words, we feel it when we turn our head or lie back, and it is usually accompanied by neck pain. It rarely occurs without neck pain. Cervicogenic vertigo and your benign paroxysmal positional vertigo are often confused with each other. You mentioned that distinguishing between them is important and that we see this very frequently. How can we distinguish benign paroxysmal positional vertigo from this, Professor Nargız?
Benign paroxysmal positional vertigo, as its name suggests, is benign, meaning non-malignant, paroxysmal, meaning it develops suddenly and lasts for a short time, and positional, meaning it changes with position. It is a type of vertigo that occurs when the patient turns their head from right to left in bed, tilts it backward, or gets up from bed. In these patients, a feeling of fullness in the ear can definitely occur. At the same time, nausea and very rarely vomiting can also accompany it. This condition is commonly known among the public as crystals moving. First, it is necessary to diagnose this patient. For diagnosis, we use a maneuver called the Dix-Hallpike maneuver. If we have made the diagnosis, we always try to reposition the patient's crystals using a maneuver called the Epley maneuver. So, do you recommend rehabilitation for these patients, doctor?
Yes, in fact, rehabilitation is often forgotten. It actually has significant benefits. We implement a program called vestibular rehabilitation for these patients, both to help them regain their balance and to improve their quality of life. It's very important for these patients to achieve proper head and eye coordination. For this, there are exercises called gaze stabilization exercises. How does this work? We draw a dot, a focal point, or an object on a card and ask the patient to look at this focal point while moving their head. In this way, we help the brain adapt again. Another exercise we use is called habituation exercises. In this exercise, what we do is have the patient repeatedly perform the movements that trigger their dizziness. After a while, the body adapts to this, and that feeling of vertigo starts to decrease. These patients often have a strong fear of falling. To prevent this, we work on balance exercises. We also do trunk stabilization exercises. Anxiety is also very common. They absolutely do not want to move and usually remain inactive, which leads to a loss of muscle mass in these patients. To prevent this, we do muscle strengthening exercises. We provide walking training so that they don't remain immobile and can become more active. And generally, we get good results. Of course, this process requires a lot of patience, but after a while, patients really come back saying their vertigo has decreased. And when it comes to vertigo related to us, specifically those originating from the neck, what is the focus there? After identifying that, for example, if the trigger point is in the anterior muscle group, this usually presents as dizziness when the patient tilts their head back. We can perform injections at the trigger points in that area, and we can also use taping techniques. We have physical therapy modalities, and we make use of those. If the trigger point is in the back, again, we apply various physical therapy modalities and exercises to that area. And with neck-related cases, of course, we achieve much more successful results much more quickly.
So then,
What would you like to say as a final word?
may your head spin only from happiness.
Yes, let's just say may it spin only from happiness.